So I certainly want to thank you and the other leaders of this meeting here, Professor Kyriopoulos, for inviting me. I have many friends here. And so today what I want to talk about is patient cost sharing. I know many of you are concerned that you've experienced tremendous cutbacks in your healthcare system, but there's no formal process yet in place to restructure the system to adapt to these new realities. And what I'm going to do is talk about patient cost sharing. No matter what happens in your new system, I'll guarantee you there'll be patient cost sharing involved in how the system works. That's on both the public side and the private side. And my background in this area is interesting because I spent about 15 years working on the largest patient cost sharing study ever undertaken in the United States. But I also spent many years working for a large insurance carrier in the United States where I administered programs, and our major strategy for controlling costs was patient cost sharing. So I bring both an academic and an applied experience in this area. So what I'm going to briefly do over here is give you some definitions so we all have a common understanding of what I mean by patient cost sharing. We're going to examine the objectives, what we're trying to achieve with patient cost sharing. And then based on the literature, my experience in this area, we're going to look at how other OECD countries manage their systems, their cost sharing systems, and try to take a look at the effect of cost sharing on expenditures, utilization, and health status. And then I end with a few strategic recommendations. So we're talking about patient cost sharing at the point of service. That means when the patient goes to a physician or a hospital or dentist or a pharmacist, they pay a certain portion of the bill out of their own pocket. And that's what we're talking about over here. You're familiar with the major cost sharing methods. I'm not going to go through each one of them, but I would say that all of them include deductibles. That's an upfront amount, generally a small amount per family, that you have to exceed in order for the insurance payments to kick in, to start. And it's meant to reduce unnecessary care, and it's also meant to reduce the administration of a lot of small bills. Co-payments, that's always a part of the system, and that's a fixed amount that you pay, say, for an outpatient visit. It's much simpler to administer than co-insurance, which is a percentage of the total cost for that visit. And for elective services where you're trying to control costs, most of them include a maxima. So for example, in the United States, for dental insurance, they'll pay $1,000 a year and no more. Beyond that, it's your responsibility. And finally, the biggest decision you make when it comes to patient cost sharing is what services are you going to cover in your national plan. Obviously, if it's not a covered service, then the patient is responsible for the total amount. Again, in the United States, cosmetic surgery is not a covered benefit under any of these plans, and you have to pay for that totally by yourself. Now, generally the way it works is that there's a limit on the amount of out-of-pocket expenses that you can bear before you become eligible for free care. So people who have catastrophic events in their life, they have to pay a lot of money in this cost sharing, but it's say after they get over, say, 5,000 pounds or 5,000 euros or so, then they're eligible for free care. And finally, in most plans, and in most countries, you can buy private insurance to cover the risk of having high out-of-pocket expenses. So that's a separate system, and you can do that whether you're having private insurance or public insurance. So when you think about it, patient cost sharing is a demand-side strategy to control healthcare costs. And your objectives, you've got three major objectives. One is you're trying to come up with a way to help the financing of care. You've got three major sources of revenue coming into your system. You've got money being paid from the general revenues taxation. You've got sometimes employer contributions and employee contributions to the premium. And finally, then you have patient cost sharing. Now, in addition to help fund the operation, the health plan, you're also concerned about social equity. In other words, it makes intuitive sense that you don't want to have a person who's desperately poor and a very wealthy person pay the same amount of cost sharing. Because obviously for the poor person, it's going to be a major barrier to care. Well, for the wealthy person, it's going to be not an issue at all. So there are certain subpopulations that you want to protect and to make sure that they have adequate access to care when you come up with your cost-sharing system. So the cost-sharing system is not going to be the same for everybody. And finally, as you all know, especially for you who are clinicians, some services are far more effective in producing health than others. And what you'd like to do through the cost-sharing system is to promote the services that are effective and reduce the use of services that are not effective. But we want to put this in some larger context. And the larger context is there's a whole range of supply-side controls too. What do I mean by a supply-side control? If you have a global budget, that determines the amount of money going into the entire system. Another supply-side control would be how many physicians do you have, where are they located, how are they trained, how are they paid. It could be how you introduce technology into the system, where your facilities are, how many, what types, what's their relationship. Those are supply-side types of strategies to control costs. And for reasons that I'll get into later, there's overwhelming evidence that supply side are far more important in controlling healthcare costs than the demand side. You need both, but supply side are really important. And I'll tell you the reason for that as we get into this. So, if you look at OECD countries, some 70 to 30% of total family healthcare costs are paid through patient cost sharing. The average is around 13 to 15, 17% in most European countries. The countries with the highest cost sharing are Switzerland and Japan, and I believe the 7% is France. So how does that compare to Greece right now? You have a cost sharing system. Some of it's legal, some of it's illegal, or what you call side payments. Our best estimate from talking with Professor Kyriopoulos and others of you at this meeting, it's probably running between 40 to 50% of total expenditures for healthcare in this country is now coming from patient cost sharing in the Greek system. So it's clear that in terms of total expenditures of where revenues are coming from, you're depending upon side payments and legal cost sharing to a far higher degree than other OECD countries. And you have the disadvantages that you cannot control the side payments so that it doesn't affect, so that it affects people of different social classes or kinds of diseases differently. So there's more social equity in the system. So those are some of the limitations in the current system. Now, what we've learned is that you can have the same cost sharing by type of per medical services. Obviously, the more expensive the services, the less the cost sharing should be. So for hospitals, it's running 3 to 5%. Outpatient, 10 to 15%. Drugs higher, and dental is even higher. So your cost sharing, it depends upon the type of service. But then you have to have this issue of social equity, and it's generally around special groups in your society, certain diseases, and certain services are exempt from cost sharing. Not necessarily totally, but at least it's recognized that these people cannot pay the full amount, and you don't want them to pay the full amount. So what are the groups that generally most countries put into this special group that have lower cost sharing? Obviously the low income, children, pregnant women. In most countries, if you're wealthy and pregnant, you have the full cost sharing, but if you're poor and pregnant, then you have a special exemption and you don't pay the same amount. It also varies by disease, and obviously if you have severe mental health problems like schizophrenia, you would not normally require them to pay for medical services at the same rate as you would with someone without that severe mental disease. because you want them to access to care because you know what happens when they don't access to care. It's the same thing with other kinds of catastrophic events. And finally, most countries say preventive services are so valuable that we'll reduce the cost sharing for preventive services. But we all know that some preventive services like immunization are very effective, but others, we're not sure how effective they are in producing health, like an annual physical. But nevertheless, most countries reduce cost sharing for preventive services. Oh, I went in the wrong direction here. Okay, so what we know from the study that I was involved in the literature, so let me tell you a little about the study I was involved in. It was the largest demonstration program of cost sharing ever undertaken by the US government. It involved 15,000 people who were selected to be representative of the entire population, and we randomly assigned them to different cost sharing groups, and we followed them for 15 years to see what effect cost sharing had on expenditures, utilization, and health status. And based on this literature and other studies that have been done since then, what we know is a few things about cost sharing. First of all, when you increase cost sharing, you do depress utilization. No question about that. But the problem is the average patient cannot distinguish between high value and low value services, so both are reduced. Secondly, some services are far more price sensitive than others to cost sharing. An example is outpatient care. A lot of outpatient care is elective, and in most countries, 60% of 50 to 60% of hospital admissions are not elective. There's a trauma involved, a heart attack, or some sort of other major condition. So you can affect the use of outpatient care far more than you can affect the use of hospital care. But other services that are very price sensitive are pharmaceutical, emergency, dental, vision services, and so forth. And you've got to be really careful, especially when it comes to pharmaceuticals, that you do not increase utilization. You don't increase cost sharing for certain conditions that are used to treat very vulnerable patients like those with schizophrenia. So many studies have been done to show that if you increase the drugs used in schizophrenia, you'll reduce utilization of those drugs, but guess what? Your hospitalization goes way up because these people then lose control. Now here's a major finding, and that is most cost sharing has a limited impact on health. For the middle and upper middle class, for the kinds of cost sharing that we've talked about over here in today's presentation, that is 7% to 30%, you could probably increase cost sharing substantially more for those upper income populations and have no impact on health. On the other hand, for low and middle income patients, what they found is that modest increases in high blood pressure, dental disease, more patients who didn't have corrected vision, and for people with serious mental health problems, if they were low and middle income, they had real problems as a result of cost sharing. So one has to be very sensitive to the fact that those people with those kinds of conditions need certain exemptions from the cost sharing arrangements. And of really importance is that for the sick poor, we actually saw a 10% increase in mortality rates associated with higher blood pressure and cardiovascular problems. So for that sick poor population, cost sharing can be a major, major issue in terms of their health status. But for the bulk of the population, the middle and upper middle classes, cost sharing doesn't seem to affect their health status. So what kind of recommendations can you point out over here? First of all, you need a point of service cost sharing system for all services. And I know in this country you have a highly regulated public system, but an unregulated private system. Well, in most countries, both systems have certain types of regulations. So for example, in the United States now, all private insurers can't spend more than 15% on the administration of the plan. 85% of the money has to go to patient care. That's a government regulation of the private system. So you don't want to think about this as private versus public. Both need some level of regulation to make this cost-sharing system to work. Secondly, you probably want to finance some 10 to 20% of expenditures, and you're way exceeding that right now with your side payment system. Secondly, you want to reduce your cost sharing for high-risk groups, and we know what those high-risk groups are, mainly related to poverty, certain diseases, and special populations. And for the most part, that does not exist within the Greek system at this point in time. We want to vary cost sharing by service category. And another thing is you've got to be humble about this, and you've got to start off with a very simple system, especially starting off. Once you start getting really complicated and neither the physicians or the hospitals or the patients really understand what's going on, you're going to find yourself in a lot of trouble. Plus that, your administrative expenses to managing the systems are going to be very high if it's a very complex system. So the idea here, as you reorganize the Greek system, start off with a simple system, and over a period of years, you can add complexity as you try to deal with the special problems in your population. And finally, you have to enforce provider and patient compliance. In other words, you have to stop the side payment system. And there's a very interesting article on the Bulgarian system where they've had side payments, and now they have a legal system of patient cost sharing. And what they found after 5 years or so, both systems are still going on. So it's not that easy to change. But you also need patient compliance too. They've got to pay their co-payments, they've got to pay the deductible, they have to pay the things that they're responsible for paying. And so both are necessary. So finally, let me end up and pose a question. I started off by saying that supply side controls are far more important than demand side. Although the demand side is certainly going to be an integral and necessary part of your program. And the reason is this, that if one looks at the distribution of healthcare expenditures in your population, what you're going to find is that about 15% of the people account for 80% of expenditures. And who are these people? These are people who have catastrophic events take place in their life. They fracture their skull or their femur. They have schizophrenia. They have heart disease. They have cancer. A lot of these patients are elderly and will live a relatively short time. And that's why the total amount of money in the system, how you deal with technology and those other issues are so important, because that's where the money is. You're not going to solve your cost control problem just through patient cost sharing. So thank you.
Thank you very much, Howard. Is there any question that you would like to? And I may help you just to ask you, first of all, you did touch on the Greek situation also, but not extensively. But you may know that because of the crisis, the co-payment policy or strategy, as you say, is imposed, and this has created a lot of problems and makes us to measure really the effects of this type of co-payments, especially in the drug, in the provision of drugs, you know, and this is, and the second, this presentation and some of the numbers that you mentioned, they refer to Obamacare type of situation. You didn't mention at all whether the Obamacare looks at the co-payment in a different way somehow.
Obamacare only affects around 15 million people out of 320 million, so one has to put this in some perspective. But he has added controls over the overall private system. And one that I mentioned is that we're going to control your profitability. Obviously very controversial, but it was accepted by the insurance industry that says you can't keep 30% of the premium and use it as profit and administrative costs. We're only going to give you 85%.
Yeah.
In other words, we're going to give you 15%. 85% has to go to patient care.
Yeah.
So in your system right now, what percentage of your costs are going into administration? Of your total premium that you spend on healthcare in Greece, what percent is spent on administration? It varies hugely by country.
Διοικητικό κόστος, well, λειτουργικό κόστος. It's not really very high in our case, because cuts are imposed also on the administrative type.
That's a critical number that you got to know. And who's spending it and for what? And can those costs be reduced, those administrative costs be reduced so that more of the money can go to patient care rather than administration?
Yeah.
So that's it's an issue. But that's one of many, many issues, as you know.
Yeah. Before Professor Boletis... όχι από εκεί.
Μπορείτε, αν θέλετε, με το κινητό σας, σε αυτή τη διεύθυνση να γράψετε τις ερωτήσεις. Και θα τις δει ο μιλητής και θα απαντήσει. Επομένως, αν υπάρχει κάποια ερώτηση, μπορείτε να την περάσετε.
Τόση πρόοδο, πού φτάσαμε. Και τότε εμείς τι ρόλο παίζουμε εδώ πέρα. Λοιπόν, έχετε καμιά ερώτηση? Έλα. Τι λέει, top question. Can you see it, Howard, there? In your screen?
Oh, yes.
Yeah. Yes. What are the most important KPIs? What is KPIs? That a healthcare system should track co-payments.
So that's not a simple question. That's not a simple question, and there's no simple answer. I mean, you have to have fundamental control over the whole thing. So every time there's a transaction, that transaction has to become part of a larger database so that you can look at individual patients and track their co-payments and what you owe the patient in terms of insurance payments. You got to do the same thing for individual physicians, and you have to do the same thing for group practices or hospitals or what have you. So you need a comprehensive database that you can look at and manage the system. Without that database, let me tell you, you're wasting your time, because there's a million ways to game this system if you don't have any data. I'll give you a good one. We had a system for outpatient care for our physicians in our private plan that the patient was responsible for 20% of the care, or $20, whichever. And what they would do is, in order to increase demand, is forego the co-payment. So what's the effect of foregoing the co-payment? It increases patient demand. So it increases their overall income by not collecting the co-payment. So you've got to know that, and you've got to be able to stop that. And we sued them and got the money back from them because they were doing something illegal. And they have to sign a contract. This is the way we're going to behave. And if you don't behave that way, then you're subject to legal redress. So short answer to your question is you need a comprehensive data system. And it's got to be computerized. There's no way. You've got all these thousands of transactions that one can do this on paper. But the sophisticated information systems now that are available on computers are so great that it should not be a major issue for you.
Okay, thank you, Howard. That's very good. Is there anything else? John, you want to say something? Huh? Okay, thank you very much. That's very good. All right.